Okay, good morning, everyone. Just 1 second. I'll just check if our audio and video is working.
Just I just give me a 2 minute time, Nikhil.
Yes, sir. No
Here I
worries.
am also
No
doing the
worries.
thing.
Yeah, no worries.
Just few minutes. The screen got blank.
No
I'm
worries.
just
No worries.
am I audible, Nikhil?
Yes, sir, you are audible.
Yeah, you can go ahead.
Okay. Okay, so good morning, everyone. This is Nikhil from Crohn's and Colitis Squad. And after a month-long break, we are back. So May is the month of World IBD Day, and just like last year, this year also we have a long campaign highlighting various issues that patients with IBD face in India, and we are going to be discussing about a lot of topics uh, in various talks that are distributed throughout this month, including mental health. And today we have with us Dr. Samrat Jankar, and he's a very talented surgical gastroenterologist and I think GI surgeon. And he's trained in very special kind of surgeries like laparoscopic surgery, robotic surgery, and he's very interested in engaging with patients also. And that's why he has agreed to do this session with us. He also has a YouTube channel where he posts very educational videos. I encourage all of you to check that out. And today we'll be hearing from him about management of perianal disease and fistulas. And yeah, I think without wasting any more time, I think I'll invite you, sir, to begin with your PPT and bless us with the knowledge. Yeah.
Thank you, Nikhil. Thank you, friends. I think it is a problem we are having, and there is not a big solution, and there is not a conclusive evidence by the medical fraternity. You people are doing a great job. I appreciate Nikhil and the team of Crohn's Colitis Squad. You are coming together, solve problem of ourselves, and guide one to one. That's really appreciating thing you are doing. I think just few words regarding this IBD. And I last near about 5 years, I am completely in colorectal thing. GI surgery is a general surgery. After that, super specialization GI surgery. I am a qualified GI surgeon. But looking at the problem of colorectal disease, particularly evolving problem of colorectal problem, my most important is IBD. I am very much interested in that. So you're looking at 5 years IBD patient, n number of patient. We have done colectomy, we have done total proctocolectomy, hemicolectomy, perianal fistula, Crohn's fistula. I think more than 10 perianal fistula I get in a year. It's really frustrating. I think most important one word by the doctor to tell about the treatment is the most important thing is it's not the disease which is because of something else is a problem. It's a disease because of our health, our thought process, our stress, which is making this problem. In fact, IBD is going to be one of the capital in the world if we go in this lifestyle. And we have to change the lifestyle, prevent someone to get. It's very untrue or it's false that every IBD patient and their generation will have no. Its disease has been born to particular person because of something wrong with us, something wrong with our health, something wrong with our lifestyle. And most of the patient we give the infliximab, adalimumab, latest anything we give, the treatment best response will come when persons stick to their good lifestyle. Something if they stick to the olden. We have to only get the question if I am eating something, is it a traditional or is it a something new I am adding? If you go back and eat whatever our ancient people are eating, 25 years before people are eating, if we go that, our IBD will get cure or it will get a better response. Even for the medication also it will help. And most important thing, just calm down. Just get stress relief. If your stress is less, the inflammatory process will also go down. If you do meditation and yoga and something which will help you to relieve the stress, which will help. And this is a wonderful platform where you people are coming together, sharing your thought, getting yourself something good ideas. Really, I appreciate your thought process. Coming to perianal fistula, today topic given by Nikhil to me, and it is also one of the favorite topic of mine, fistula, and it is the problem. It is not frustrating to the patient. Frankly telling friends, it is frustrating for surgeon also because no surgeon want his patient to come again to him, again get treated. Again, we don't know that it is going to cure or not. So it is a really big trouble. And when surgeon want heroic, that I will cure it, and he will cure it, but he will give something which is more frustrating than the fistula. That is the incontinence. Because if you want to become aggressive in the fistula surgery, you have to remove complete fistula. If you want to remove complete fistula, there is something called muscles, external sphincter that only control our continence. Continence means when we are sitting here, it is a place, it is not desired to go for the defecation. It is a place where we are telling our mind the suitability place is not suitable. So our mind will take that signal and control the defecation process. That is because of our sphincters, internal and external, predominantly external sphincter. When surgeon become aggressive, he will divide the external sphincter. I have seen many patient fistula. One last week, one patient came, 70-year person coming to meet me, and he was telling 93. One surgeon has done such a wonderful surgery. I told, what surgery? Fistula surgery. Then he was telling, before the fistula, I was having a problem that in a 6 month, I used to get some pus or some infection. I used to go to the doctor and get cured. But now I can't go to the doctor. I can't attend any program. I have been time bound. If I come to the any program, I will go eat little bit. If I eat more, I have to go to the toilet. Little bit eat, and at any condition, I will make my arrangement to reach my home because 100% I will have incontinence and I can't control my motion. And this is really, really frustrating. So it's not about the cure of fistula. Cure of the fistula without continence is the treatment for the fistula in ano or perianal abscess. With this thought process, we'll go. Sorry, friends, I am not very much technical guy. I had my previous laptop with presentation which has been prepared for a long time, but I couldn't run and I couldn't capture it here. But I am having a two videos which will give you a very much understanding about the fistula. And after that, I will share my experience of fistula in a patient with IBD, particularly cross, how to take care, what will be done from surgeon point, what is expected from the patient point, what we can expect in our lifestyle, we will go ahead. I will try to run my two videos from my YouTube channel, which will helpful for you people. Just give me a 1 minute time. Share. Oh God. Nikhil, screen is there, it is not sharing. 1 second, 1 second, 1 second. I just video is open, but that video is not sharing. Just 1 second. Some Are you seeing any video? Just a second. Okay. Just 1 second. It's working, but screen I am having two video which are not showing. Just 1 second. Yeah, it is not giving the option. Just 1 minute. Share the screen. Just now, it is showing video. 1 second. Started video. Just another 1 minute. Otherwise, I will give just talk. Am I visible? I'll just go with talk. Video is not at all. to. Yeah, I tried it. New share. Yeah, now it is showing. Wonderful. Yes, it will come now. Yes. Started? Yes. Fistula, if we want to understand about the fistula, we need to know what is a fistula, how it come, and how a doctor try to treat. So, in this, now it is started showing. Fistula means this is our anal canal. In the anal canal, we are having multiple glands. Multiple glands will be there in the perianal region. In the anal region, if you see here, there is a ridges. In this region, if suppose person has some infection, something called constipation is there, he is straining, small ulcer will form. From there, infection goes. If you see here, there are the two muscles are there on the side. Infection goes across this muscle and this comes and open to the perianal skin level. And this is the thing happen with every kind of fistula. In fact, fistula rather than fistula, we have to tell anorectal sepsis. Anorectal sepsis means anything fistula or abscess in perianal which conclude as anorectal sepsis. In that, there will be this anal region. From anal region, infection travel across the muscle. It comes out. It forms the bulge. That is a pus. So that when we see the pus, then we go to the doctor or we at the home it get rupture. Then pus will be drained out. Pus will goes out. That is a natural process where perianal abscess will be formed. What happens to the fistula when doctor drain this pus or suppose this get ruptured by itself? In those scenario, the tube will be formed. Tube will be formed. That tube will be patent, and that tube, this is a tube. This is the fistula. What happens is from inside to outside, the tube is connecting to outer skin area and inner inside it is connected to anal region. What happens naturally if some stool is there, some particle is there, it again goes into that track. Again, if it is going into that track, it will not allow the track to heal. Anything in our body, what we do, if suppose here infection happen, doctor does cleaning everything, he removes off. But in this area, what the arrow has shown to the fistula, these are the two strip of the muscle. One is called inside internal sphincter, one is called outside external sphincter. These are the two sphincter which are so much of properly God has created for us. Those are things which senses that when stool is there, when person is ready to pass the stool, everything they will sense. If suppose the person is not ready to pass, means we are sitting at an unnatural pace where we can't defecate. It is not the toilet. In those area, automatically internal sphincter relaxes, external sphincter contract. So that what happen, it will become tight so much, it will tell that it's not the right time to go for the motion. It will avoid the motion. By doing that, it will give us comfort in a social condition. But through those two sphincter, if something is going out and we are just opening that outer area and draining the pus, what naturally happen inside collection water is we are seeing it is because of that Nikhil, some echo is going on. You are mute. Okay. Okay. That track is there. Because of the track, continuously some infection will go fecal matter, and again it will continuously get infected, and person will have again and again infection. What natural history patient will have? I had an infection, perianal. Doctor has done the surgery, pus he has removed. Again I'm getting infection. And previous infection has been not. How the fistula is happening? Because the natural course is inside tract we are not removing. Why doctor surgeon is not aggressive to remove? Because surgeon has to take care that your sphincter also not supposed to get damaged. That's what the natural story happens. And out of, if suppose 100 patient people get the perianal abscess, out of that 30% of the people naturally the track will get closed, but 60 to 70% there is destined to get a fistula in a future until and unless the surgeon takes care of both fistula and abscess at the initial part. That was a natural story for any fistula. So if you go ahead to see, usually what here has been shown, you can see here multiple anal gland at the dentate level, and we call as intersphincteric space. Intersphincteric space means we have seen that it is the internal sphincter, this is the external sphincter. In between the two, there is the space that is called intersphincteric space. And that space is the most culprit for any kind of perianal sepsis, perianal abscess, or anal fistula. Why it is a culprit? Because what happens if you see here in mouth we have some ulcer. What will happen to the mouth? Will just become, we will not open beyond certain. But is it the same thing will happen in the perianal region? No. In the perianal region, if we have pain, then also how much quantity of stool has to pass. It is not at our control. It is a natural which will happen. It is a involuntary. It is not our control. We can start the process, but bulk of the, is it 2 centimeter stool will pass, is it 4 centimeter stool will pass, it is not under our control. So when there is a small, this anal gland get infected and some pus trickles in this space, suddenly this internal muscle becomes spasm. And what will happen is in between the two spaces, it get trapped. If suppose in between two spaces it get trapped, what is the way to go out for it? Internal sphincter, it get tight, it will lock inside. Then person will feel that outside we are not having anything, but there is a pain in the perianal region. That perianal pain person will have, or proctalgia means I am feeling some discomfort in the perianum, but doctor is telling nothing is there. Why it happens is initial part when this cryptoglandular infection happen in between the two sphincter, pus will get trapped. What natural thing should happen? That pus either has to resolve, it will not resolve because any infective pathology, if it doesn't goes out, if you give n number of antibiotic, it will not resolve. So it has to come out. How it will come out? Either doctor will identify it will drain, or it has to go in between. Is there? It has to go through it. We call it a transpindric route. And if it becomes fistula, we call it a transpindric fistula. If it is goes up, we call it a high intersphincteric fistula. If it is going down, low intersphincteric fistula. That kind of naturally it will take its route and it will open up at the verge, means at the anal opening, or it will take a long distance, it will open outside. It will take a long distance, it will open outside. Some patient will experience that whole abdomen level is getting pus because perianal region things are not opening. It will take a route to coming upper side. Those are less number, but it will take that route also. That's what the natural history happen in the perianal fistula. What is actual cause for fistula? Anything, if we want to talk on the fistula, is the cryptoglandular infection. Why that infection happen? There are two reasons. One is the person is having constipation or person is passing the hard stool. Because of passing hard stool, somewhere they will form the small ulcer or somewhere they will form the infection at a gland level. Because of that gland infection, it form the intersphincteric abscess and it will become the fistula. Or other rare causes, cancer may come as a fistula presentation. Some anal cancer may present. For that reason only, whenever we are having the fistula, it's not about the treatment of the fistula. We should know that other anything is a reason is there. And many patients, CA rectum patients, CA anal canal patient, if they get a radiation, because of that radiation, fissure and fistula is common. Or some patient, because of inadvertent trauma, something has happened accident, because of the trauma in the perianum will happen. Also, most important is IBD patient. IBD patients are having the fistula. In fact, fistula may present in IBD. The Crohn's will suffer from the fistula. Crohn's patient will suffer from the fistula. And how the Crohn's patient will present with the fistula, sometime perianal fistula, young patient presenting with the perianal abscess, recurrent perianal abscess or recurrent fistula. First thing we think TB or Crohn's, but nowadays TB is getting cured in India or in fact in the world. But then comes the most important. The TB is decreasing, but Crohn's or IBD is increasing. In IBD or Crohn's patient, fistula may come before Crohn's getting diagnosed, or fistula come along with diagnosis, or fistula come after your diagnosis. 30% of the Crohn's patient diagnosed because of the fistula. When they have recurrent fistula, doctor get fear, surgeon get fear. What is going on? Why is not getting cured? He is having multiple opening. Why I have done 2 times surgery? Why is not curing? For that reason, they put the colonoscope. When they put the colonoscope, story changes completely because he has a Crohn's, which is not allowing to him heal his fistula. And Crohn's fistula surgery is not going to heal. We have to think something beyond. I think you are familiar with all these things. Infliximab, adalimumab. I have seen a lot of posts of you. Azothioprine and infliximab. In fact, infliximab, there are good trials, good studies are telling infliximab, adalimumab, irrespective of what is the problem going on, until and unless you give biological, these fistula will not dry. Surgery is not the treatment. The treatment is medical treatment. When you medically treat this patient, remove the acetone, it will get cured. And also most important is, if we do surgery for Crohn's fistula, that patient has more chance for incontinence. So if at all we are giving perianal abscess or perianal fistula, we think twice. Or if you are having someone is our friend in this Crohn's colitis squad, IBD person is having the perianal abscess or perianal fistula or perianal fissure, when you go to the doctor in perianal problem, you should reveal your IBD status to the doctor. Even though you are IBD in the resolution phase, we have to reveal that I am having IBD and I am having a perianal. The hell difference is there in a non-IBD person treating perianal problem, IBD treating perianal problem. Because IBD treating perianal problem, if we go aggressive surgical management, surgery is not going to cure, but going to land in incontinence, which is not acceptable. And in IBD person, surgery is secondary or surgery is rarest needed. Treatment is medical treatment. Care the perianum with some sort of conservative management, kind of seize bath, application of the local ointment, taking care of the perineum. If there is a abscess is there, draining the abscess, putting the acetone. These are the few things we need to do in IBD patient with perianal problem. But most important is perianal, either fissure or fistula or hemorrhoid. The treatment is medical treatment, not surgical treatment. If we don't reveal that our IBD status and we go with the perineal problem, destined to have complication which are very difficult to manage. So we have to take message that I am IBD person and it's not a big disease. It's kind of nowadays kind of diabetes and hypertension. If I am having IBD with me, if I am having a perineal problem, I have to reveal to the surgeon that I am IBD person. Don't do anything before thinking doing. You think multiple times that I need to get treated medically, not by surgically. If you tell IBD, no surgeon will have courage to touch that fistula or perineal abscess. That's what we have to take a strong message from this.
Excuse me, sir.
What is the actually presentation of hello?
Yeah, so I had a question. So, like, even if the IBD is like say a person is in remission and still they are having fistula, so even then, like, it's related to IBD or like.
Yeah, no. What is actually thought process is, until and unless proven that perianal fistula and person with IBD, until and unless proven, we should take it as a IBD related fistula. Why we are telling that? Because if we take other fistula, if I have in mind our thought, our school of teaching, our professor, what they used to tell us is, if I am having in thought that it may not be IBD fistula because person is in remission, if you take that wrong decision or wrong thought to treat that patient, the problem what we are going to have that person, it's not about the curing the problem, it's about the quality of the person. If we do the inadvertent surgery thinking my thought process or my gut feeling that I am a surgeon, you are an IBD person and your IBD has been curated, I will tell you that your IBD is in the resolution phase and I will go ahead with the surgery and it will cure. No, because IBD resolution or not resolution depends upon the three components. One is your activity score. For Crohn's colitis, you have Crohn's disease activity score or multiple scores are there, biochemical markers and endoscopic resolution. Those all three things, if comes the resolution and you are having a simple fistula, we can take as a non-IBD fistula. If you are having any marker raised, your Crohn's disease activity score is high, or ulcerative colitis, your Mayo score and Tuller-Witt score is high, and you are having endoscopy-wise ulceration, granulation, erythema, friability. I am talking all these things, guys. See, you guys are talking, discussing this N number. So I am just talking as those words. Endoscopy wise, we are seeing that mucosa is not good. Erythema is there, redness is there, inflammation is there, ulceration is there. That is active disease. Or we are having your biochemical marker, fecal alpha-protectin is raised, WBC is raised, your C-reactive protein is raised, or your ESR is raised, HB is low. These are all things coming together, define that are you in a resolution. A best modality to define your resolution is endoscopy. But every person we can't do endoscopy. So all things together, if you feel it is in a resolution phase, and also perianally you are having a simple fistula. What is mean by simple fistula? Simple fistula is you just see the fistula which has single opening, which is not recurrent again and again. It is not coming. It is not having multiple openings. They are not there. And also you are having the fistula without abscess, just fistula tract is there. Such a scenario we can tell is a simple fistula. If it is a simple fistula, we can take it as a non-IBD fistula. But anything is wrong. It is a pinch of salt to take as a non-IBD, because this will make surgeon also very much unhappy and also make a IBD patient also unhappy, because he was having a simple fistula and in big trouble. We don't have to do. So every fistula IBD person, even though it is a resolution, take it as an IBD fistula. And before doing your any surgical procedure for perianum, get done the colonoscopy, confirm that endoscopy wise there is complete resolution of IBD, and at least 6 months you are drug free, then only you should think getting done the surgery. My frank, genuine advice for any fistula person with IBDs, don't get done surgery until and unless we are sure, surgeon is sure what we are doing. Okay. And what are the presentation? Presentation of the perianal fistula is simple perianal pain. Person may have continuous nagging pain. Nagging pain is something is there. I am not comfortable. That kind of presentation will be there. Sometimes person will have fever with chills, which will goes out. Or sometimes person will feel that some point is tender, some point is painful, and it is not resolving. Those are the things will come. Extreme itching will come. First if comes, then it is diagnosis of fistula or perianal abscess. That's for the sure. And how we diagnose? Diagnosis of fistula or perianal abscess is very easy. It's a perianal. We see the disease. We see hard area before abscess get ruptured. We see the soft area where we can fluctuate. Means we press it, it get compressed. That is usually rare scenario in perianum. Perianum is something is painful and you press, it will feel hard, and pressing also gives a pain to the patient. That is called tenderness. That will be the classical presentation of perianal abscess. Fistula is very easy. You are having opening outside and pus is coming out. That's what the perianal fistula. So if we are having a fistula, we have to do the evaluation. In the evaluation, multiple things are there, but clinical diagnosis is most important. We need to do at least MRI, TRUS or MRI or colonoscopy. Out of the 3-4 things and pus culture sensitivity. First of all, if you got perianal abscess or fistula, you take the pus, send for the culture sensitivity. What will it does is culture sensitivity is doctors send that pus to the lab to grow the organism, and the organism which is sensitive to which antibiotic, so that the firing towards the organism to treat that it will become easy during this process, or if we are having again and again problem, it will be easy. And some thought process is there. E. coli related will be very difficult to treat. Staph aureus related perianal abscess is sometimes it will be easy to get treated. So second important thing is what kind of the fistula? Is it simple fistula? Is it complex fistula? In fact, most of us, there are good studies are there telling most of us means we surgeons, we gastroenterologists, we think that this is a simple 30% of the simple fistula when done MRI, they found out that it is a complicated. They found out that something else is missing. So MRI doing plus reading the MRI by good surgeon or good radiologist will give you better cure, because the surgeon and radiologist will be definitely sure what surgery to be done, definitely sure how much you are having risk of incontinence. Every time it will come the question that I am having a problem, how much chance to get cured. At the same time, appendix cure 100%, but if fistula at the same time of the cure, we have to ask equally how much I am going to have an incontinence. So for those two questions to solve, MRI is the best investigation, and MRI is the one of the gold standard. Some people expert can do TRUS, but TRUS will vary from person to person. TRUS, what they do is they put a scope. The TRUS scope, TRUS probe. What do we do? Ultrasound. They put ultrasound in the perianum. They see, but it needs the expertise of the TRUS. TRUS is something everyone can't do. Even though you are having a big and costly and machine in the institute, the reporting depends upon the surgeon qualification, surgeon understanding, surgeon radiologist understanding, radiologist expertise. So I feel, rather than the TRUS, MRI maybe we personally feel that MRI is the best, because this person can see, CD can you send to another radiologist, he can read, surgeon before surgery again, rather than reading the words again, he can see the images, again he can take a better decision for the treatment. So when we treat the fistula, another important thing is colonoscopy. Irrespective of your IBD status or non-IBD status, colonoscopy is mandatory, because recurrent fistula, we have to rule out anything else we are missing. Anything else is most important is IBD Crohn's disease. 30% of the fistula will have Crohn's inside, which they don't know. We know that how the Crohn's presents, sometimes perianal pain, sometimes abdominal pain, and we are having for 6 months. And after 6 months, we come to diagnosis that there is a fistula is there, there is a Crohn's is there. So 30% of the perianal fistula have the Crohn's inside. So those things we need to rule out. So for that reason, we need to understand. So understanding perianum, this is bit of complicated. Then also I try to simplify. We see that there is an internal ring. This is the rectum is coming, and internal sphincter is there, and the levator is coming, external sphincter is there. Those two A and B, what I mentioned, those are the most important thing to maintain our continence, to maintain our social justice, where to pass the motion and where not to pass. If we come to the surgical aspect, this is what I want to. We are not supposed to. Recurrence means again and again we are getting the fistula. Incontinence means we are not able to control the motion. Person can live with a fistula whole life. I have seen multiple people. The person cannot have a good life, quality of life with incontinence, because he can't be socially go at any place. So that is a very horrible scenario. So it's not about the surgeon, it's about the both surgeon and patient, not about asking recurrence. Recurrence plus incontinence, both things has to balance. Then we will get a good result. It's getting completely cured fistula, living with incontinence is the worst thing. You have to have a fistula cured. At the same time, you should not have 1% recurrence or 2% recurrence of fistula is acceptable. 100% incontinence is not acceptable. There are the procedure. I have told there is simple fistula, complex fistula. I usually what the doctor decides is a person having again and again fistula is complex fistula. Person having fistula with big abscess, multiple opening is complex fistula. And most important thing is external sphincter, whole external sphincter involving fistula is complex fistula, because he has to cut the external sphincter, chances of incontinence will be high. In a particularly female, the anterior fistula, a fistula between the anal region and urinary region, in between, if it is there, that is very much complicated fistula, because that side, the sphincter, the word I am using, sphincter, that controls the continence, that will be very thin. Chances of getting incontinence is high. Those are all complex fistula, and IBD associated, Crohn's associated, radiation associated is complex fistula. If complex fistula is there, we have to do some special surgery which are called sphincter preserving surgery. And if it is a simple fistula, fistulotomy. Fistulotomy means we open complete fistula and we allow it to heal, and we cut the sphincter at certain level. That is called fistulotomy. Let's see fistulotomy how it will be done. Fistulotomy, from external opening to internal opening, surgeon will cut and they will open it, and there will be a wound. We ask the person, daily do the dressing, sit, do the sis bath. By this maneuver, that will completely get healed. It will heal. It will take at least 3 to 4 weeks. Natural healing of perianal wound is usually 4 to 6 weeks. If it is dragging more, definitely we have to think, is there any fistula is there? And seton. What is seton? Seton is nothing but either it can be tube, either it can be a sling, vascular sling, or it can be a thread, or sharp sutra, or all things are seton. And sharp sutra is nothing but medicated thread. So what the surgeon does is, we are seeing that it is going from outside and it is going inside and knotting outside. So there will be internal opening and outer opening. Over that there will be a thread, and it can be used in two ways. It can be used, what Sharp Sutra people does is, they multiple time they ask the person to come and they tighten. The every tightening person will have pain, and after 2 days pain will goes up and it will become loose. Again he will tighten, so that over the period of time gradually tightening, it will get completely cut in few days. It will take from 3 months to 6 months to get done. That is a cutting seton. That is a cutting Sharp Sutra kind of thing. But in fistula patient with Crohn's or perianal abscess with Crohn's, what we does is, we put a seton which is a loose. What is the purpose of that is, in that tract, something abscess again and again should not form. And by doing this, when there is no abscess on the perianum, or there is no infection in the perianum, only fistula is there, the person surgeon will be happy to start the biological. In the biological, we can start. What is the problem of biological or infliximab is, when there is an infection, we give biological, infection will become flare up. So we have to remove the pus. Once we remove the pus, we have to keep the thread or tube as a seton and allow it to drain, allow it not to collect. By doing that, that area become dry. Once this dry area is there, then we bombard with the medication, azathioprine, infliximab, adalimumab, which will help to heal. We have seen many patients after 2 to 4 doses, after 2 to 6 months of time, when we remove the seton, the fistula of IBD magically will close by itself. So that is the usually gold standard treatment for any fistula associated with IBD, particularly Crohn's. And this is what the lift or walk technique. What is this technique? I am not talking of all the thing, but few of the things are important. The lift or waft is also one of the good technique where we are having complex fistula. We have seen simple fistula, fistulotomy. That is the best treatment. If it is a complex fistula, if IBD fistula, give the seton. I have done few of the patient IBD lip procedure. What is a lip procedure is? Lip procedure, if you see this video, in this video, there is a track, 2 track I have seen, which is connecting from inside to outside. Those 2 tracks are there. What happens is, this is a fecal matter coming, which will go through the tract. And when one fecal matter go through the tract, because fecal matter 1 gram contains millions of bacteria, once it goes, it will cause the infection. Because this infection has happened outside, the usual story will be outside, they have done the drainage, they have removed the pus. Again in 2 months, I got another one pus, because inside opening is open, patent. That opening allowed the fecal matter come and collect in that tract, and that infection again becomes the pus. Again person is getting the pus. So that pus will form. And naturally in fistulotomy, we cut whole this tract, so there is no chance of again getting. But when complex fistula is there, what are the option? Lift or walk will be the option. In the lift, what we do is we take root, we take a root in between the two tracks. We take a root in between the two tracks. In between the two tracks, surgically we go. Person will be sleeping on the stomach on the table. We go in between the sphincter and we make a space between the sphincter. We ligate on the both the side of the track. By ligating both the side of the track, what will happen is the track will get completely closed and outside will clean out. We are not damaging the muscle and we are cleaning the track and we are keeping sunnies on the safe side. That's what the lift. And in fact, whatever available treatment, if simple, best treatment is fistulotomy. But when complex, when we don't want, if you see in this image, we are not damaging either sphincter. The best treatment for a person with a complex fistula is lift, where we are not at all dividing the sphincter. And once we do this, then fecal matter, even if it is some, it will not be well. And what in laser they do, they will put laser fiber through the track and they will burn hole the thing and they will take a stitch at the opening. So because of that, there is a chance that it will not going to recur. But personally, my personal experience is better than the laser lift is a good. But nowadays, what I have started is I will take a track, outside I will burn with the laser, inside I will do the lift. In fact, it is giving very good result. Not 100%, but almost 97-98% of the patients are getting cured by the laser lift. Laser lift is a one thing which I have started by my own. So, in fistula patient, perianal patient, or any patient, the IBD or Crohn's having the perianal problem, most important thing is not surgery, most important thing is not medication, most important thing is a sitz bath. I want to stress again, most important thing is a sitz bath. What sitz bath is? Sitz bath is nothing but sitting in the warm water. I feel sitting in the warm water, traditional way of doing sitz bath is take a large bucket and pour the water, sit in that. It will become cumbersome. If I think in the nowadays almost 90% of the people having a Western toilet at the home. If you see Amazon, if you see any surgical site, you can get a sitz bath tub, which is very cost friendly. It is hardly 500 rupees. What you have, that tub you have to place on the your toilet, any toilet it accommodate, and over that pour the warm water. Water should not be too hot. It will burn your perineum. It will cause many complications. Water should not be cold. It will not solve the purpose. What we have to do is pour the water over the sitz tub and sit over that. And the water should be not warm, not warm, not cold. It is a lukewarm, little bit warm. You have to open the anal region and contract, making that it will clean the perianum, it will clean the perianal fistula, it will clean the fissure, it will also help grade 1, grade 2 hemorrhoid also get cured. So this is most important thing in the perianal problem of any person having, and particularly Crohn's person, we don't want surgery. It is the most important thing. Sitz bath is the important key of whole management. You can sit, person is sitting and contracting, relaxing is also important. In the perianal region, this can be easily removed and you can throw out the water. It is done. So
I think, sir, like before moving, like we have questions from people. So before that, I think like I would just like to summarize because that is a lot of information, and I think like what I'm feeling is like fistula is very complex topic, and like it's very difficult to balance things also, and that's why like many like patients with fistulas they have a like greater level of dissatisfaction usually because the management is very like complicated. So
in fact, one word I want to tell, what we surgical community tells that if we are having an enemy surgeon, refer that fistula to that enemy so that he will also get screwed by the patient. That's what
So, like perianal abscess is the beginning of a fistula. Like if it's
Yes,
worsened, then a fistula will happen. And if a patient does not have IBD or any other condition, then it's relatively simple to manage. When a
yeah,
person has IBD or any other condition, then it's difficult, and then we have to maintain a balance between like preventing the fistula from becoming complex and preventing incontinence also. And
yes,
incontinence, yeah, it's really difficult to live with total
manage.
incontinence. So that's why, and even the management options for a complex fistula, like they take a lot of time, like months. So
Yes.
that's why it's very difficult. And we have one question. It's like can fistula be developed if there's like recurrent diarrhea, long-term diarrhea? So can that be a reason for developing a fistula?
No, 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 no. Usually not. Ulcerative colitis patient many times has a diarrhea. The diarrhea will not cause a fistula. In fact, diarrhea may cause a fissure. Fissure is nothing but you are having a pain in the perianal region. When you pass the motion, particularly hard motion, you will have that 5 minutes of hell of the pain. That is the fissure. The fissure is common in the ulcerative colitis diarrhea patient, not the fistula. Fistula is will not associated with diarrhea. Usually it is associated with the constipation.
Okay. And sir, like why like this perineal abscess? Why does it happen? Like what are the sources of infection? Like because of which this happens?
That's what I told. When you see the anal region, inside it is a smooth. It's naturally anal region will close and it will open up 2 centimeter, 2.5 centimeter. The person suppose having a constipation, he has not passed the motion because of taking less water, less fiber, because of some stress, travel, lot of problems are there. Suddenly one day he passed the motion in 2 days or 3 days with lots of straining, he passed a hard stool. When we pass a hard stool, anal can open up to 3-4 centimeter. But when we stretch too much, it will cause the erosion. It will cause the injury to anal region. And that injury at the level of anal gland that is getting exposed to the fecal material. And there the story start, the perianal abscess, intersphincteric abscess, fistula story start. So not getting the fistula, best way is avoiding the constipation. And also one important thing is perianal hygiene. Sometimes if we are traveling 2-3 days in different places, hot weathers, and everything is sweating, and if we are fail to take a hygiene of the perianal region, it will start small boil kind of thing, and it will also form the fistula.
And so another question is if a patient has like recurring fissures, so like does like do they have to fear about a fistula or like what is sort of
Yeah, yeah, yeah. When we are having recurring fissures, there also fissure is nothing but cut at the anal region. Because of the cut at the anal region, again there is a chance that it will start accumulating the fecal material. That fecal material is a source for forming the abscess and fistula. Chronic fissure impact has a chance to form the fissure going turn into the fistula. That is also possible chance.
okay. And sir, do like while doing this sits bath, so some people add salt and some people add betadine. So like what is the best amount to do?
Actually, salt, when we take, it is hygroscopic nature, it will help. But personally, I feel we want warm water, which will help to clean, which will help smoothen that perineum. That's the purpose of warm water. Along with that, adding the betadine, which will give antisepsis. This much is enough. Personally, I am preferring towards the doing correct bath. Correct bath is your anus should be dipped in the water. Water should be lukewarm. It should not be hot or cold. When you sit over the water, you have to be relaxed and it should be at least 5 to 10 minutes. In that 10 minutes, your anal region continuously open and close, open and close. If you do that, you will get the best result. Over that, adding 10 ml of betadine in 1 liter of water will give antisepsis. It is nothing but cleaning. I think this much is enough. Water adding add as a hygroscopic, but I personally don't recommend. This much is enough.
I'm sorry, we have small amount of time, so like I like you said you're going to share some experience about a patient. So I think yeah.
Yeah, Crohn's patient. Friends, I had many. In fact, I just moved from the Tamil Nadu to Chennai. to the Pune. I am working at Symbiosis University Hospital. This is new setup. Here I didn't get that much, but every month I used to have two or three patient, Crohn's patient coming as a fistula. Lot of thought processes there, lot of problems people are there. First of all, think that Crohn's associated fistula difficult to manage. First of all, accept that thought process. If I tell you that I will cure your fistula in 2 days, you will not have pain, you will not have recurrence, I am 100% wrong. This never magic happen in the perianum, because perianum surgeon and also the patient has to respect, because if we don't respect and we take a wrong decisions, it will come in the next big problem. And another most important before forgetting, fistula never going to cause the cancer. So many people are coming to me asking that I am having Crohn's fistula, chronic fistula. Is it a chance for cancer? No, fistula has not proven to cause cancer. Fistula will remain as a fistula, but sometime you are having a fistula, there may be cancer inside, you have to rule out. So fistula never going to cause a cancer. So that we have to take into the mind. So I had many people who has come with a perianum whole pus. In those patients also, we just drain the pus, we put a fistula set on, which has helped the patient getting cleaned up the perineum. And many patient we have removed the set on completely in 3 month period of time. Patient has recovered completely. So you need not to worry. But as compared to normal, Crohn's patient with fistula take longer time. Time may be 3 months, time may be 1 year, and only surgery for the perineal fistula, not cure for the Crohn's patient or IBD patient. The cure for the IBD patient is the fistula, is the fistulizing Crohn's disease, is the biological, and also even you get a cure for the fistula, your motion defecation should be good. You have to have a good perineal hygiene, and whatever your course of medication going on, depending upon your disease severity, your biochemical marker, your endoscopic picture, you need to take azoran or mesalamine. You have to take for longer disease to avoid again getting fistula.
Yeah, so I think what I understand is like if you have a fistula, then it's going to take a lot of effort from the patient side also and from the GI side also to manage it and to manage their expectations also, like, and it's going to take a long time. So like I think the patient and both the surgeon and the GI also have to be patient, very
Yeah,
patient.
patience is the key for this treatment.
Yeah. So, sir, like final question would be then like what can a patient do to avoid a fistula? Because like since it's so
That's right.
problematic.
I tell one thing: the best way to live healthy is to have good bowel.
Yeah.
I think you also agree with me.
Yeah.
Because why IBD we are suffering, because our bowel is not good. Why bowel problem has came, because not we are maintaining our healthy lifestyle. Westernization of our lifestyle is the culprit, because Crohn's disease we didn't had 10 years before, we didn't had this much. Every OPD young person, Crohn's is not like cancer. It is a disease which is affecting youngsters. And youngster who is the most productive for his life, who is the most productive for his family, he is spending a lot of money for his health, and he, because of us, family is also suffering. So to avoid all this problem, avoid the fistula, avoid the IBD, I feel we have to take a motto that our bowel is happy, my health is happy. Happy bowel will give a happy, healthy life. So keeping bowel happy, we need to avoid the constipation. To avoiding the constipation, I always prefer eat healthy, live good Indian lifestyle, and drink more water and have good fiber, which will prevent your all the problem. One thing, it will not allow you to come into the problem. Even if you're in the problem, it will help you to cure. And even if it is not in the curing state, it will help you to maintain your good quality of life.
Yeah. Thank you, sir. I think that's the end of our time. So thanks a lot
Thank you.
for
Thanks a lot.
discussing this topic.
Thank you for giving the opportunity. I am happy to help you people. If anything is there, anything guidance needed at any time, you can tell me. I will try to help.
Thank you, sir. Thank you.
Thank you.
Yeah, I think like you have a lot of videos on your YouTube channels, and I've seen a lot of content from your side also, and I think like that I really appreciate because I think fistulas and abscesses these are not really discussed also because uh, patients are not very comfortable in discussing these topics with each other also,
Yeah,
and
yeah, yeah,
these are
yes,
very
yes.
poorly understood topics. So thank you for shedding a light on
Okay.
these details and answers.
Thank you for giving opportunity to have a little bit knowledge of mine with you people.
No,
Thanks a lot.
thank you for like accepting our invitation, like for giving us this chance to talk to you, and it was very helpful. So yeah,
Thanks a lot. Thank you.
I think
Thanks a
you have
lot.
to go to a surgery now. So yeah,
Yeah, your phone is belling.
yeah.
I need to go for
So
surgery.
yes, so thank you, and yeah, like please stay safe, and yeah, we'll
Yeah,
see you
take,
next time.
take, take.
Thank you, sir.